functions of the respiratory system are to obtain oxygen from the external environment and supply it to the cells, and to remove from the body the carbon dioxide produced by cellular metabolism. The respiratory system is composed of the lungs, the conducting airways, the parts of the central nervous system concerned with the control of the muscles of respiration, and the chest wall. The chest wall consists of the muscles of respiration, the diaphragm, the intercostal muscles, and the abdominal muscles, and the rib cage. The functions of the respiratory system include gas exchange, acid-base balance, phonation, pulmonary defense and metabolism, and the handling of bioactive materials. The lungs are contained in a space with a volume of approximately 4 liters, but they have a surface area for gas exchange that is the size of a tennis court, approximately 85 meters per square. This large surface area is composed of myriads of independently functioning respiratory units. Unlike the heart, but like the kidneys, the lungs demonstrate functional unity. That is, each unit is structurally identical and functions just like every other unit. Because the divisions of the lungs and the size of disease are designed by their anatomical locations, it is essential to understand pulmonary anatomy in order to comprehend respiratory physiology and pathophysiological alterations in respiratory diseases. The respiratory system begins at the nose and ends in the most distal alveolus. Thus, the nasal cavity, the posterior pharynx, the glottis and vocal cords, the trachea, and all divisions of the tracheobronchial tree are included in the respiratory system. The upper airway consists of all structures from the nose to the vocal cords, including sinuses and the larynx, whereas the lower airway consists of the trachea, airways, and alveoli. The upper airways condition inspired air so that by the time air reached the trachea, inspired air is at body temperature and fully humidified. The nose also functions to filter, entrap, and clear particles larger than 10 micrometers in size. The inferior of the nose is lined by respiratory epithelial cells interspersed with surface secretory cells. These secretory cells produce important immunoglobulins, inflammatory mediators, and interferons, which are the first line of host defense. The paranasal sinuses, frontal, maxillary, sphenoid, and ethmoid, are lined by ciliated epithelial cells and surround the nasal passages. The cilia facilitate the movement of mucus from upper airways and clear the main nasal passages approximately every 15 minutes. The functions of the sinuses are first, to lessen the weight of the skull, which makes upright posture easier. Second, to offer resonance to the voice. And third, to protect the brain from frontal trauma. The fluid covering their surfaces is continually being propelled into the nose. In some sinuses, for example the maxillary sinus, the opening ostium is at the upper edge, which make them particularly susceptible to retention of mucus. The ostia are readily obstructed by nasal edema, swelling, and retention of secretion and secondary infection, sinusitis, can result. The volume of nose in an adult is approximately 20 milliliter, but the surface area is greatly increased by the nasal turbinates, which are series of three continuous ribbons of tissue that protrude into the nasal cavity. The nose enables the sense of smell. Neuronal endings in the roof of the nose above the superior turbinate carry impulses through the cribriform plate to the olfactory bulb. Pharynx is divided into three sections: the nasopharynx, oropharynx, and laryngopharynx. Important structures within these regions include the epiglottis, vocal cords, and arytenoid cartilage, which is attached to the vocal cords. The nasopharynx, 2 to 3 cm wide and 3 to 4 cm long, is the most anterior and lies behind the nose. In this region, the nose and mouth are connected via isthmus that enable both oral and nasal breathing. Also, the nasopharynx contains small masses of lymphoid tissues, also known as pharyngeal tonsils, which fight infections. The nasopharynx is connected to the middle ear cavity via the Eustachian tubes, which equalizing pressure in the ear to atmospheric pressure. Thus, they represent a drainage pathway of lymphatic fluid between the throat, nose, and ears. This network of structures provides means of fighting infections, but also is a common location for infections in the head. The soft palate separates the nasopharynx and the oropharynx, which ends in the epiglottis. The laryngopharynx begins in the epiglottis and ends in the esophagus. Its major role is to help regulate the passage of food into the esophagus and air into the lungs. With some infections, these structures can become edematous and contribute significantly to airflow resistance. The epiglottis and arytenoid cartilage cover or act as a hood over the vocal cords during swallowing. Thus, under normal circumstances, the epiglottis and arytenoid cartilage function to prevent aspiration of food and liquid into the lower respiratory tract. The act of swallowing food after mastication usually occurs within 2 seconds, and it's closely synchronized with muscle reflex that coordinate opening and closing of the airway. Hence, air is allowed to enter the lower airways, and food and liquids are kept out. Patients with some neuromuscular diseases have altered muscle reflexes and can lose this coordinated swallowing mechanism. Such patients may become susceptible for expiration of food and liquid, which poses a risk for pneumonia. The right lung, located in the right hemithorax, is divided into 3 lobes: upper, middle, and lower, by 2 interlobular fissures, oblique and horizontal, whereas the left lung, located in the left hemithorax, is divided into 2 lobes: upper, including the lingula, a tongue-like projection of the anterior aspect of the upper lobe and lower by an oblique fissure. Both the right and left lungs are covered by a thin membrane called the visceral pleura and are encased by another membrane called the parietal pleura. The interface of these two pleura allows for smooth gliding of the lungs as it expands in the chest and produces a potential space. Air can enter between the visceral and parietal pleura by trauma, surgery, or a rupture the group of alveoli. The resulting condition is pneumothorax. Fluid can also enter this space and create a pleural effusion, or in case of severe infections, emphysema. The trachea branches into two main stem bronchi. These main stem bronchi then divide, like branches of the tree, into lobar bronchi, one for each lobe, which in turn divide into segmental bronchi, and then into smaller and smaller branches, bronchioles, until ending in alveolus. Bronchi and bronchioles differ not only in size but also by the presence of cartilage, the type of epithelium, and their blood supply. Beyond the segmental bronchi, the airways divide in dichotomous or asymmetrical branching pattern. Bronchi distinguished by the size at the presence of cartilage eventually become terminal bronchioles, which are the smallest airway without alveoli. Each branching of an airway results in an increase in the number of airways with smaller diameters. As a result, the total surface area for the next generation of branches increases. Terminal bronchioles terminate in opening duct to a group of alveoli and are called respiratory bronchioles. The region of the lung supplied by a segmental bronchus is called bronchopulmonary segment and is the functional anatomical unit of the lung. Because of their structure, bronchopulmonary segments have become irreversibly diseased, can easily be removed surgically. The basic physiological unit of the lung is the gas exchanging unit, respiratory unit, which consists of the respiratory bronchioles, the alveolar duct, and the alveoli. The bronchi, which contain cartilage, and the terminal bronchioles, in which cartilage is absent, serve to move gas from the airway to the alveoli and are referred to as conductive airways. This area of the lungs, approximately 150 milliliter in volume, does not participate in gas exchange and form the anatomical dead space. The respiratory bronchioles with alveoli and the area beginning with the respiratory bronchioles to the alveoli are where all gas exchange occurs. This region is only approximately 5 mm long, but it's the largest volume of the lung. At volume approximately 2050 milliliter and with a surface area of the 70 meter per square, when the lung and chest wall are the resting volume, the alveoli are polygonal in shape and approximately 250 micrometer in diameter. Alveolar space are responsible for most of the lung's volume. These spaces are divided by tissue known collectively as the interstitium. The interstitium is composed primarily of lung collagen fibers and is a space in which fluid and cells can potentially accumulate. an adult approximately 5 times 10 to the 8 power alveoli, which are composed of type 1 and type 2 epithelial cells. Under normal conditions, type 1 and type 2 cell exist in 1:1 ratio. The type 1 cell occupied 96% to 98% of the surface area of the alveolus, is the primary site for gas exchange. The thin cytoplasm of type 1 cells is ideal for optimal gas diffusion. In addition, the basement membrane of the type 1 cells and the capillary endothelium are fused, which minimized the distance for gas diffusion and thereby facilitates gas exchange. Type 2 cells are cuboidal and usually found in the corners of the alveolus, where they occupy 2% to 4% of the surface area. During embryonic development, the alveolar epithelium is composed entirely of type 2 cells, and only very late gestation do they differentiate into type 1 cells and form the normal alveolar epithelium for optimal gas exchange. Also, type 2 cells synthesize pulmonary surfactant, which reduces surface tension, non-sticking properties in the alveolar and thereby promotes less resistance during inhalation and exhalation. Gas exchange occurs in the alveoli through a dense mesh-like network of capillaries and alveoli called the alveolar capillary network. The barrier between gas and the alveoli and the red blood cell is only 1 to 2 micrometer thick and consists of type 1 alveolar epithelial cells. Capillary endothelial cells and their respective basement membrane. Oxygen and carboxygen passively diffuse across this barrier into plasma and red blood cells. Red blood cells pass through the network in less than 1 second, which is sufficient time for carboxygen and oxygen gas exchange. The circulation to the lung is unique in its duality and ability to accommodate large volumes of blood at low pressure. The lung has 2 separate blood supplies, one for the uptake of oxygen and removal of carboxygen from the body, its pulmonary circulation, and the other to supply oxygen to lung tissue, bronchial circulation. The pulmonary circulation begins in the right atrium of the heart. Deoxygenated blood from the right atrium enters the right ventricle via the tricuspid valve and is then pumped under low pressure 9 to 24 mm per mercury into the pulmonary artery or pulmonary trunk, which is approximately 3 centimeters in diameter and branches quickly 5 cm from the right ventricle into the right and left main pulmonary arteries, which supply blood to the right and left lungs, respectively. The arteries of the pulmonary circulation are the only arteries in the body that carry deoxygenated blood. The deoxygenated blood in the pulmonary arteries pass through a progressively smaller series of branchous vessels. Arteries diameter more than 500 micrometer, arterioles and capillaries that end in a complex mesh-like network of capillaries. The sequential branching pattern of the pulmonary arteries follows the pattern of the airway branching. The functions of the pulmonary circulatory system are to reoxygenate the blood and release carboxygen, to aid in fluid balance in the lung, and to distribute metabolic products to and from the lung. Red blood cells are oxygenated in the capillaries that surround the alveoli, where the pulmonary capillary bed and the alveoli come together in the alveolar wall in unique configuration for optimal gas exchange. Gas exchange occurs through this alveolar capillary network. The total blood volume of the pulmonary circulation is approximately 500 milliliter, which is approximately 10% of the circulating blood volume. Approximately 75 milliliter of blood is present in the alveolar capillary network of healthy adult at any one time. The pulmonary capillary bed is the largest vascular bed in the body. It covers a surface area of 70 to 80 meter per square, which is nearly as large as the alveolar surface area. During exercise, the pulmonary capillary blood volume increases from 75 milliliter to as high as 200 milliliter because of the recruitment of new capillaries as a result of increase in pressure and flow. This recruitment of new capillaries is the unique feature of the lungs, and it allows for compensation in periods of stress, as in the case of exercise. The oxygenated blood leaves the alveolus through a network of small pulmonary venules and veins. These small vessels quickly coalesce to form larger pulmonary veins, through which the oxygenated blood returns to the left atrium of the heart. In contrast to the arteries, arterioles and capillaries, which closely follow the branching pattern of the airways, venules and veins run quite distant from the airways. The arteries of the pulmonary circulation have thin walls with minimal smooth muscle. They are 7 times more compliant than systemic vessels, and they are easily distensible. This highly compliant state of the pulmonary arterial vessel requires lower pressure for blood flow through the pulmonary circulation than do the more muscular, non-compliant arterial walls of the systemic circulation. The vessels in the pulmonary circulation under normal circumstances are in dilated state and have larger diameters than do similar arteries in the systemic system. All of these factors contribute to a very compliant, low-resistance circulatory system, which aids in the flow of blood through the pulmonary circulation via the relatively weak pumping action of the right ventricle. This low-resistance, low-work system will also explain why the right ventricle is the less muscular than the left ventricle. The pressure gradient differential from the pulmonary circulation from the pulmonary artery to the left atrium is only 6 mm per mercury, 14 mm per mercury in the pulmonary artery minus 8 mm per mercury in the left atrium. This pressure gradient differential is less than 7% of the pressure gradient differential of 87 mm per mercury present in the systemic circulation, or 90 mm per mercury in the aorta, minus 3 mm per mercury in the right atrium. not well-defined anatomically, vessels in the pulmonary circulation can be divided into three categories: extraalveolar, alveolar, and microcirculation, on the basis of differences in their physiological properties. The extraalveolar vessels, arteries, arterioles, veins, and venules, are larger than their systemic counterparts. They are not influenced by alveolar pressure changes, but they are affected by intrapleural and interstitial pressure changes. Thus, the caliber of extraalveolar vessels is affected by lung volume and by lung elastin. At high lung volumes, the decrease in pleural pressure increases the caliber of extraalveolar vessels, whereas at low lung volumes, increase in pleural pressure decreases vessels' caliber. In contrast, alveolar capillaries reside within the intraalveolar septa, and they are very sensitive to change in alveolar pressure, but not to change in pleural or interstitial pressure. Positive pressure ventilation increases alveolar pressure and compresses these capillaries and thus blocks blood flow. The pulmonary microcirculation comprises the small vessels that participate in liquid and solid exchange in maintenance of fluid balance in the lung. The sequential branching of the pulmonary arteries culminates in a dense mesh-like network of capillaries that surround alveoli. This alveolar capillary network is composed of thin epithelial cells of the alveolar and endothelial cells of the vessels and their supportive matrix. And it has an alveolar surface area of approximately 85 meters per square, the approximate size of tennis court. The structural matrix of the tissue components of this alveolar capillary network provide the only barrier between gas in the airway and blood in the capillary. The cells of this barrier, which is 1 to 2 micrometer thick, include type 1 alveolar epithelial cells, capillary endothelial cells, and their respective basement membranes, which are back-to-back. Surrounded mostly by air, this alveolar capillary network is ideal environment for gas exchange. Red blood cells pass through these capillary components of this network in single file in less than 1 second, which is sufficient time for carboxygen and oxygen gas exchange. In addition to gas exchange, the alveolar capillary network regulates the amount of fluid within the lung. At the pulmonary capillary level, the balance between hydrostatic and oncotic pressure across the wall of the capillary result in a small net movement of fluid out of the vessels into the interstitial space. The fluid is then removed from the lung interstitium by the lymphatic system and enters the circulation via the vena cava in the area of the lung hilus. In normal adults, an average of 30 milliliters of fluid per hour is returned to the circulation via this route. The bronchial circulation is a distinct system, separate from pulmonary circulation in the lung, that provides systemic arterial blood to the trachea, upper airways, surface secretory cells, glands, nerves, visceral pleural surface, lymph nodes, pulmonary arteries, and pulmonary veins. The bronchial circulation is similar in structure to the systemic circulatory system and perfuses the upper respiratory tract. It does not reach the terminal or respiratory bronchioles or the alveoli. Venous blood from the capillaries of the bronchial circulation flows to the heart either through bronchial veins or bronchopulmonary veins. True bronchial veins are present in the region of the lung hilus, and blood flows into the azygous, hemiazygous, or intercostal veins before entering the right atrium. The bronchopulmonary veins are formed through a network of tributaries from the bronchial and pulmonary circulatory vessels that anastomose and form vessels with admixture of blood from both circulatory systems. Blood from these anastomosed vessels returns to the left atrium through the pulmonary veins. Approximately 2/3 of the total bronchial circulation is returned to the heart via the pulmonary veins and this anastomosis route. The bronchial circulation receives only approximately 1% of total cardiac output. In comparison, the pulmonary circulation receives almost 100%. In the presence of diseases such as cystic fibrosis, the bronchial arteries, which normally receive only 1 to 2% of cardiac output, increase in size, hypertrophy, and receive as much as 10% to 20% of the cardiac output. The erosion of inflamed tissue into these vessels as a result of bacterial infection is responsible for hemoptysis, coughing up blood, that can occur in this disease. Breathing is automatic and under control of the central nervous system. The lungs are innervated by the autonomic nervous system of the peripheral nervous system, which is under CNS control. The autonomic nervous system has 4 distinct components: parasympathetic, sympathetic, non-adrenergic, non-cholinergic inhibitory, and non-adrenergic, non-cholinergic stimulatory. Stimulation of the parasympathetic nervous system leads to airway smooth muscle constriction, blood vessel dilation, and increased glandular cell secretion, whereas stimulation of the sympathetic system causes relaxation of the airway smooth muscle, constriction of blood vessels, and inhibition of glandular secretion. The functional unit of the autonomic nervous system is composed of preganglionic and postganglionic neurons in the CNS and postganglionic neurons in the ganglia of the specific organ. As with most organ systems, the CNS and PNS work in concern to maintain homeostasis. There is no voluntary motor innervation in the lung, nor are there pain fibers. Pain fibers are found only in the pleura. The parasympathetic innervation of the lung originates from the medulla in the brainstem, cranial nerve tends the vagus nerve. Preganglionic fibers from the vagal nuclei descend in the vagus nerve to ganglia adjacent to airways and blood vessels in the lung. postganglionic fibers from the ganglia then complete the network by innervating smooth muscle cells, blood vessels, and bronchial epithelial cells, including goblet cells and submucosal glands. In the lungs, both preganglionic and postganglionic fibers contain excitatory, cholinergic, and inhibitory non-adrenergic motor neurons. Acetylcholine and substance P are neurotransmitters of excitatory motor neurons. Dynorphin and vasoactin intestinal peptide are neurotransmitters of inhibitory motor neurons. Parasympathetic stimulation through the vagus nerve is responsible for a slightly constricted smooth muscle tone in the normal resting lung. Parasympathetic fibers also innervate the bronchial glands, and these fibers, when stimulated, increase the synthesis of mucous glycoprotein, which increases the viscosity of the mucus. Parasympathetic innervation is greatest in the larger airways and most limited in the smaller conducting airways in the periphery. Whereas the response of the parasympathetic nervous system is very specific and local, the response of sympathetic nervous system tends to be more general. Mucous glands and blood vessels are heavily innervated by the sympathetic nervous system. However, airways smooth muscle is not. Neurotransmitters of the adrenergic nerve include norepinephrine and dopamine. Also, dopamine has no influence on the lung. Stimulation of the sympathetic nerves in mucous glands increases water secretion. This disrupts the balance response of increased water and increased viscosity between the sympathetic and parasympathetic pathways. Adrenergic fibers are absent in humans. In addition to those in the sympathetic and parasympathetic system, afferent nerve endings are present in the epithelium and in smooth muscle cells in the lung. Breathing is an automatic, rhythmic, and centrally regulated process with voluntary control. The central nerve system, particularly the brainstem, functions as the main control center for respiration. Regulation of respiration requires generation and maintenance of a respiratory rhythm, modulation of this rhythm by sensory feedback loops, and reflexes that allow adaptation to various conditions while minimizing energy costs, and recruitment of respiratory muscles that can contract appropriately for gas exchange. The major muscles of respiration include the diaphragm, the external intercostal muscles, and the scalene muscles, all of which are skeletal muscles. Skeletal muscles provide the driving force for ventilation. The force of contraction increases when they are stretched and decreases when they are shortened. The force of contraction of respiratory muscles increases at a larger lung volumes. The diaphragm is the major muscle of respiration, and it divides the thoracic cavity from the abdominal cavity. Contraction of the diaphragm forces the abdominal contents downward and forward. This increases the vertical dimension of the chest cavity and creates a pressure differences between the thorax and abdomen. In adults, the diaphragm can generate airway pressure of up to 150 to 200 cm H2O during maximal inspiratory effort. During quiet breathing, tidal breathing, the diaphragm moves approximately 1 cm. However, during deep breathing maneuvers, vital capacity, the diaphragm can move as much as 10 centimeters. The diaphragm is innervated by the right and left phrenic nerves, whose origins are at the 3rd to 5th cervical segment of the spinal cord C3 to C5. The other important muscles of inspiration are the external intercostal muscles, which pull the ribs upward and forward during inspiration. This causes an increase in both the lateral and anterior-posterior diameters of the thorax. Innervation of the external intercostal muscles originates from intercostal nerves that arise from the same level of the spinal cord, T1 and T2. Paralysis of these muscles has no significant effect on respiration because respiration is dependent primarily on the diaphragm. This is why individuals with injuries to the lower spinal cord can breathe on their own. It's only when the injury is above C3 that individual is completely depends on the ventilation. Accessory muscles of inspiration, the scalene muscles, which elevate the sternocleidomastoidus muscles, the alveoli, which cause nasal flaring, and small muscles in the neck and head, don't contract during normal breathing. However, they do contract vigorously during exercise and when airway obstruction is significant. They actively pull up the rib cage. During normal breathing, they anchor the sternum and upper ribs. Because the upper airway must remain patterned during inspiration, the pharyngeal walls muscles are also considered muscles of inspiration. All the rib cage muscles are voluntary muscles that are supplied by intercostal arteries and veins and innervated by motor and sensory intercostal nerves. Inhalation during normal breathing is passive, but it becomes active during exercise and hyperventilation. The most important muscles of exhalation are those of the abdominal wall, which oppose the external intercostal muscles. The inspiratory muscles do the work of breathing. During normal breathing, this workload is low, and the inspiratory muscles have significant reserve. Respiratory muscles can be trained to do more work, but there is a limit to the work that they can perform. Respiratory muscle weakness can impair movement of the chest wall, and respiratory muscle fatigue is a major factor in the development of respiratory failure. The epithelium of the lung arises as a pouch from the primitive foregut at approximately 22 to 26 days after fertilization of the ovum. Single lung bud branches into primitive right and left lungs. Over the next 2 to 3 weeks, further branching occurs to create the irregular dichotomous branching pattern. Is present 3 laws of lung development. First, the bronchial tree has developed by week 16 of intrauterine life. Second, alveoli develop after birth. The number of alveoli increases until the age of 8 years.
and the size of alveoli increases until growth of the chest wall is completed at adulthood. And third, the development of preational vessels, arteries and veins, parallels that of the airways, whereas that of intraacinar vessels parallels that of the alveoli. Thus, intrauterine events that occur before 16 weeks of gestation will affect the number of airways. Conditions known as congenital diaphragmatic hernia is an example of congenital lung disease. It occurs at 6 to 8 weeks of gestation and is due to failure of the pleuroperitoneal canal to close and thereby separate the chest and abdominal cavities. The presence of the abdominal contents in the lungs hemithorax results in abdominal lung growth with a decrease in the number of airways and alveoli. Before the birth of affected infant, the alveolar epithelium is composed solely of type 2 epithelial cells, and it's not until birth that these cells differentiate into type 1 epithelial cells. Growth of the lungs is similar and relatively proportional to growth in body length and stature. The rate of development is fastest in the neonatal and pre-adolescent period, and girls' lungs mature earlier than boys. Also, the growth rate of the lungs slow after adolescence. The body and lungs increase in the size steadily until adulthood. Improvements in the lung functions occurs at all stages of growth development. However, once optimal size has been attained in early adulthood, 20 to 25 years of age, lung function starts to decline with age. The decrease in lung functions with age, estimated at less than 1% per year, appears to begin earlier and proceed faster in individuals who smoked or are exposed to toxic environmental factors. The major physiological insufficiency caused by aging involves ventilatory capacity and responses, especially during exercise, and they result in abdominal ventilation with normal perfusion. In addition, gas diffusion decreases with age, probably as a result of decrease in alveolar surface area. Age-related decreases in lung functions and altered structure parallel biochemical observation of increased levels of elastin within the lungs, which could explain some of the functional abnormalities. Lung volumes. First, tidal volume is the volume inspired or expired with each normal breath. Second, inspiratory reserve volume in the volume that can be inspired over and above the tidal volume is used during exercise. Third, Expiratory reserve volume is the volume that can be expired after the expiration of a tidal volume. Residual volume is the volume that remains in the lungs after a maximal expiration. Cannot be measured by spirometry. Fifth, dead space, anatomic dead space, is the volume of the conductive airways, is normally approximately 150 milliliters. B. Physiologic dead space is a functional measurement, is defined as the volume of the lungs that does not participate in gas exchange, is approximately equal to the anatomic dead space in normal lungs, may be greater than the anatomic dead space in lung diseases, in which they are ventilation divided by perfusion defects, is calculated by the following equation. In words, the equation states that physiologic dead space is tidal volume multiplied by a fraction. The fractional represents the dilution of alveolar pressure of carboxygen by dead space air, which does not participate in gas exchange and does not therefore contribute carboxide to expired air. 6. Ventilation rate. Minute ventilation is expressed as follows. Minute ventilation, tidal volume times breaths per minute. Alveolar ventilation is expressed as tidal volume minus dead space multiplied per breaths per minute. Sample problem. A person with the tidal volume of 0.5 liter is breathing at the rate of 15 breathing per minute. The partial pressure carboxide of his arterial blood is 40 mm per mercury, and the partial pressure of carboxide of his expired air is 36 mm per mercury. What his rate of alveolar ventilation? Lung capacities. Inspiratory capacity is the sum of tidal volume and inspiratory reserve volume. Functional residue capacity is the sum of expiratory reserve volume and residual volume. Vital capacity or force vital capacity is the sum of tidal volume, inspiratory reserve volume, and expiratory reserve volume. Is the volume of air that can be forcibly expired after a maximal inspiration. Total lung capacity is the sum of all four lung volumes. Is the volume is the lungs after a maximal inspiration. Include residual volume, so it cannot be measured by spirometry. Forced expiratory volume. Forced expiratory volume is the volume of air that can be expired in the first second of the forced maximal expiration. Forced expiratory volume is normally 80% of the forced vital capacity, which is expressed in the formula. In obstructive lung disease, such as asthma, forced expiratory volume is reduced more than forced vital capacity. In restrictive lung disease, such as fibrosis, both forced expiratory volume and forced vital capacity are reduced in either normal or is increased.